போட்டோல தெரியவே மாட்டாங்களே இல்லையா
இல்ல மேடம்
எப்படி வேணும் புட்டா பரவாயில்லையா
Team B there.
Team B will be 2. Hey, careful. 2. Your buzzer will be 2. Hey, team A is there. A is there. B is this. Thank you. Mic. Okay. ஒரு டீமுக்கு மட்டும் மைக் இல்ல இன்னொரு அவ்வளவுதான் இருக்கா சரி பரவாயில்லை இது கொடுத்துறோம் சரி ஓகே இல்லனா இந்த மைக் கொடுத்துறோம்
Team C from Stanley Medical College, Dr. Priya and Dr. Padmalata.
Team C.
Team D from CMC Vellore, Dr. Kirtana Jacob and Dr. Janslin.
Congratulations, all of you. So before we progress to the quiz, I would like to check whether your buzzers are checked. I mean, like working. So kindly give us a time before we start. Wait a moment. எங்க தெரியுது எந்த டீம் அமுக்குறாங்கன்னு எங்க தெரியுது அந்த ஸ்கிரீன் can it be அந்த buzzer can be brought it on the stage முடியாதோ buzzer stage கொண்டு வர முடியுமா அத கொண்டு வர சொல்லுங்களேன் அங்க வெச்சிடுங்க so that everybody can be like everybody can see the buzzer அந்த ஸ்டேஜ்க்கு நடுவுல வெச்சிடுங்க
இங்க வெச்சிருங்க நான் பாத்துக்கலாம்
Buzzer யாரு
அவங்களே தெரியாத எல்லாருக்குமே தெரியுது நீங்க சென்டர்ல வெச்சா சென்டர்ல எங்க வெச்சிக்கலாம் ஓகே ஃபைன் அப்படியே கார்னர்ல வெச்சிடுங்க அந்த கார்னர்ல வெச்சிடுங்க ஓகே fine சரி team 1 please press your buzzer we would like to see whether it is we are able to see that okay போதும் விடுங்க team 1 have you pressed buzzer இல்ல வரல team 1 க்கு வரல buzzer இல்ல அது ரீசெட் பண்ணுங்க இல்லனா வராது just reset the buzzer please reset பண்ணுங்க buzzer இல்லனா வராது then team 1 not coming சரி okay we'll go with team 2
buzzer on
இல்ல வரல buzzer வரல team 4 team 3 இது வருது team 3 but you didn't press at all
இல்ல யாரும் பிரஸ் பண்ணாதீங்க ஒரு நிமிஷம்
when 2 is pressing 3 is coming
அத 3 கொடுத்துருங்க அப்ப அத 3 கொடுத்துருங்க
we cannot move without the buzzer being set team yes team 1 press
மாத்திருங்க
4 ல இருக்கு
அந்த buzzer எங்க யூஸ்
ஆமா no they can reset it there one please press perfect thank you reset that team 2 please press reset it to 2 3 னு வருது 2 பண்ணனும் இல்லடா அது 1 2 3 4 பார்த்து தான் நாங்க உட்கார்ந்தோம் அதுல பஸ்ஸர் நம்பர் எழுதி இருக்கு that is how we sat team 2 press இல்ல team 2 press இல்ல இல்ல அப்படி வேணா மாத்தி 3 ல விடுங்க
அப்படியே மாத்திடுங்க
மாறி உட்கார வேண்டாங்க
இல்ல மாறி உட்கார்ந்துருங்க அவ்வளவுதான்
பஸ்ஸர் தூக்கிடலாம் மேடம் இட் பி வெரி கன்ஃபியூசிங் ஏபிசிடி மாத்த முடியாது மாத்தி உட்கார்ந்தனா ஏபிசிடி ஒரு டர்ன்ஸ் அதுவும் சரியா வராது வரல ஆண்ட்ராய்ட்ல எல்லாரும் டக்குன்னு தூக்குனா யாரு டக்குன்னு அந்த டக்குல டக்கு எப்படின்னு கண்டுபிடிக்க முடியாது ஆமா அதான் இல்லைன்னா யாருமே பண்ணல.
அது எப்படி வருதோ அந்த பஸ்ஸரை மட்டும் மாற்றி கொடுத்துடலாம்.
Microsecond we cannot stay. We were standing up, madam. Sorry, okay, we will I mean.
Give them 5 minutes. 5 minutes they'll do it.
Okay.
Perfect. Team T. Reset பண்ணுங்க. Team T.
பொறுமையா வரீங்க.
Team 3, please. No,
Press.
press again.
வல்ல.
Okay.
Perfect. Reset பண்ணுங்க. Team 4 plus.
Okay.
Perfect.
Just
Thank
one
you.
more rehearsal. ஒரு தடவை press பண்ணிட்டோம். Just one more dress rehearsal.
Team 1
வரல.
வரல. Team 1 வரல.
வந்துருச்சு. பாருங்க.
Yes. Reset. 2.
Okay.
Yes. 4.
4 நல்லா இருக்கு.
வரல. 4 வரல. இல்ல இல்ல அது வந்துட்டு போறது. இப்போ கொடுங்க.
Okay.
இன்னொரு தடவை பார்க்கலாமா?
வேணாம். Yeah then.
We'll start, sir. Okay.
All of you have mic. Okay, perfect.
ஸ்டார்ட் பண்ணலாமா?
Just press buzzer only once. Don't keep on pressing. It will cause technical
Yes,
difficulties.
and once a beep is heard, please the other teams don't press again. Once the beep is heard, some team is already pressed, so there's no point in pressing.
So we'll start our quiz. Quiz master ready? Scorer.
Master already.
So round 1 is an MCQ round. Each team will get one question. It's the first because we just want to warm you up. So it's a simple round. 10 marks if you answer, 0 marks if you don't answer. There is no pass, nothing. The next person will get the next question. Okay, because we'll begin slowly. So team A ready? First, there is only timer. So 30 seconds each. Okay. So I'm starting. First question. A 23-year-old para 2 woman at 29 weeks with diabetes mellitus, fetal Doppler could not demonstrate the fetal heart. An ultrasound confirmed an IUFD with overlapping skull bones, confirmed by 2 obstetricians. Patient insisted that she still feels fetal movements. How will you handle the situation? A, will you do a 3D, 4D ultrasound? Explain that there may be false perception, but it is definitely dead baby. Explain that there may be false perception and offer 3D scan. Refer her to fetal medicine unit. Give nasal oxygen and repeat ultrasound. Your arm starts now.
Team A question.
B option.
B. Your answer is, mic is not working?
B.
Yes, that is correct. So 10 marks to team A. Scorer? Okay. Next team. So team B, 30 seconds for you. Your question 2. A 23-year-old para 2 at 20.
Answer.
Okay, sir. A 33-year-old with 6 weeks pregnancy, bad obstetric history, APLA positive, no thrombotic event. What is the best treatment for her? Aspirin, prophylactic low molecular weight heparin, aspirin 75, therapeutic dose low molecular, aspirin and warfarin and
Team B.
time is on. As soon as my question is over, your time starts.
Option B, aspirin 75 mg plus prophylactic dose of low molecular weight heparin.
Correct. Team C. A 25-year-old gravida 1, 32 weeks gestation, admitted to the labor room with BP of 160, 110, urine albumin 1 plus by dipstick. There is no complaints of headache, blurring of vision, epigastric pain or decreased urine output. NST is reactive. Further management includes all except, the question is all except. So you have to tell the negative statement. Admission, will you admit her? Will you send an urgent CBC, LFT, RFT? You start antihypertensive, immediate cesarean if cervix is unfavorable, steroid administration.
D.
What will you do except?
D.
Correct. 10 marks for.
Can you all please be louder? We are giving you a mic. Answer into the mic. If we cannot
Team
hear
D.
you, we will mark you
Other-
0.
A 32-year-old Gravida 1 at 32 weeks came with complaints of itching. Following statements are true except, again this is an except question. Blood testing includes bile acids have to be done. Increase in alkaline phosphatase clinches the diagnosis. Possibility of early delivery and meconium stained amniotic fluid is increased. Patient requires ursodeoxycholic acid. Recurrence risk in the next pregnancy. Correct.
Correct.
Did you all guys see the slides there by any chance?
Nothing.
So that's correct. So this round everybody has done well. Everybody has started with 10. Yeah, we kept it simple so that you warm up and have some points. So second round. So and shall we start the second one? Oh, we have an audience round also. Is the audience willing?
So for the audience round, we want a single person to get up, loudly answer. No marks or no gifts for everybody to give a crowd answer. Okay, a single person giving up loud answer will give a gift.
A 26-year-old has been diagnosed with acute kidney injury following an obstetric complication. What is the most common cause of acute kidney injury in obstetrics? APH, PPH, hyperemesis, drug-induced preeclampsia.
Loudly. No. No, we will, I think we have enough passes. We'll go to the next question. Yes, but after an MCQ, 3 passes எல்லாம் வந்து கிடையாது. அதனால இல்ல. So we will not be giving it to you because nowadays we don't allow patients to have renal injury because we give them adequate fluid management. Now the most common cause is preeclampsia only.
So the rules for round 2, girls, little more thing but still very easy. So it has an image, it's a visual round. My next 2 rounds are visual only. So visual round, so there are 2 parts for the question, each carries 10 marks. So if you add 1, you get 10, then you get 10, total 20. It will be passed. This is a passing round. So again 5, 5. Okay? So if you answer 1, you get 5, you answer another, you get another 5. So I'll start with team
B.
Team B, okay? Now what is this image and what is the condition? It is 30 seconds. Time is on. You have to tell what you are seeing and then you have to give me a diagnosis. Answer only when your turn comes. Don't answer out of turn. Then for which the question is, that team will get the answer.
Time up. Pass
Time
it on.
up. It passes to team C.
Ma'am, it's a USG image of abdominal circumference of the fetus. Is this
No. Team D.
Echo.
Team D.
If you will answer out of turn, then whoever turn will give marks to them. Okay. If you will answer correct, also they'll get. Team D, your
No. Team A.
Echo image. It's a.
What? Next.
That's an apla.
What is the condition?
what are you saying?
Apla.
Huh?
Speak in the mic.
Speak in the mic. Even if it's wrong, just say it.
No.
Now it's over.
Calcium.
Anyway, you answer.
No.
Let me see what
Wait. Let them answer.
It's over.
Pass.
No, their chance is over, but you answer.
And it's Epstein anomaly.
Yes, but now you're not getting marks.
Yes, nobody is getting a mark,
Zero
but that's
marks.
the answer is
But
right.
yes, it is not fetal echo actually. It is a
Yeah.
ultrasound. Yeah, it's, the right atrium, the fetal right atrium is very big. You see, all the others are very small. There is only one which is very big, and that is the right atrium. And the tricuspid is a little lower, so it's Epstein's anomaly. Okay. No, we
Next
wanted
question,
to see
Team
the
C.
finals of all the teams across South India, so we wanted it a little.
Team C.
Team C, your 30 seconds. Now, what is this image and what condition is it used for? 30 seconds. No negative marks. You can answer whatever you want to. If it is right, you will get marks, otherwise you don't.
10 seconds more.
10
Yes.
seconds more to go.
Uterine embolism.
Tell me loudly.
Uterine embolism.
Okay. The next part of the
Say
question.
say it properly. If you don't say it properly and I can't hear it, I'm not giving
Uterine
you marks.
artery embolization.
Yes.
Correct.
It is
It is
used
not-
in the management. Used in the management of PPH.
Absolutely
Okay.
correct. They got
20
it.
marks.
So 20 marks.
20 marks for Team C. Okay. Next question, Team D.
Okay. So team D, starting the question. What is this and what is the diagnosis?
Last 5 seconds.
Yes, first part is correct. What are you saying? Say it properly. What gocha?
Diagnosis.
Anyway, fetal gocha, malady gocha.
Time over. We will pass on this question. One half of the question is partly correct. We'll go on to Team
Then
A.
they get 10 marks. Next team.
Team A.
Team A.
Team A.
The second part.
Is a late answer IUGR?
Yes.
Correct. It's a
They
late
get 5
onset
marks,
because
5
after
marks of
30,
the pass.
you see, after 32 weeks it is coming down. So it is a late onset FGR. So 10 marks to team D and 5 marks to team
Team
A.
A. Yes.
Now the question goes to team A. Correct.
Correct.
A woman underwent cesarean section for abruptio. The following intraoperative finding is seen. No.
Covilliar uterus.
Yes.
Hysterectomy is life-saving.
False.
Correct. They get 20.
Yes.
So 20 marks for team A. Team B.
No.
Achha, over. Yeah, so this is over. So next round. Okay? Okay, this is an audience round.
Ask question, madam.
What is the, this is for audience, what is the image, what are the problems during pregnancy?
Louder.
No.
No.
Only one more answer.
Okay. No,
Anybody?
you can give the answer. We'll do time
It
up.
is a chicken pox and
See, there is the back image and there are those, you know, and these are the problems with chicken pox. It is there, ma'am, see, it is there.
மேடம் அது வெசைக்கிள் தான் அது ஓவர் ஜூம்ல சரியா தெரியல next question next we'll go to the third round
பண்ணவே வேண்டாம் buzzer இது.
this is buzzer round.
Third round starts with Team C.
This is a buzzer round.
buzzer round all of you be ready with a buzzer
It's a visual round, clinical scenarios. This has been sent by Dr. Ashwath. Okay, this is Dr. Ashwath's round. Shall I start? Now it starts with team C.
buzzer round whoever
Okay,
presses
sorry. It's a buzzer round, yeah. It's a buzzer round. So it's a buzzer round. 15
rules
sec-
இருக்கு
15 seconds to press buzzer and 15 seconds to answer. Whoever first presses the buzzer gets the chance. There is no pass, no transfer. There is negative marks in this, so be careful. If you answer the two parts, you get plus 10, plus 10. If you do not answer, you get minus 5. So you either get 20, 10 or minus 5, okay? You understood the rules? So I'm starting with, acha, it's a buzzer. Now describe the syndrome in which this characteristic rash is seen.
buzzer not working so team B is lifting the hand sorry team B has lifted the hand because their buzzer was not working
Yeah.
Team B.
Livedo reticularis.
Correct. In what is it seen? There are two parts to the question. In which condition is it seen? Describe the syndrome, and in which is this characteristic rash seen? In which condition is it seen?
Many drug-induced toxicity can be there.
You want the most common.
We'll move up, ma'am. Time up.
APLA syndrome, APLS.
Correct, correct. They get it. 20.
What are the criteria?
Sapporo's criteria, which has clinical and laboratory criteria. So in clinical criteria, we have less than 10 weeks, 3 abortions in less than 10 weeks, or any preterm birth less than 34 weeks, and history of any APLA-related events. And in clinical criteria, we will have more than ACLA, beta-2-glycoprotein, and
Okay, they get it, ma'am. They get it. We give it to you. 20 marks. So it is reticularis, CD in
Yes,
APLA.
we'll move, madam. We'll move to the next.
Identify the defect and etiology.
Buzzer 2, team 2.
Team 2 has pressed.
You get -5.
Hey, no, they have not
No, I'm saying
answered.
it's a buzzer round. If you don't answer, they are not getting.
Team 2 answer.
Come on, answer anyway, -5 otherwise.
15 seconds.
It is a limb defect seen in valproate teratogenicity.
alcohol syndrome.
No, -5 for team B.
Correct, Nikran.
Fetal valproate syndrome, toxicity.
Correct only. Correct, correct. They get the mark.
10. Because valproate is okay, but
Craniosynostoses சொல்லல ஒரு மண்டையெல்லாம் போட்டுருக்கோம்ல. Only you told about limb, so we will give you 10 for that.
Fine, okay.
so team B has got 10 marks.
மண்டை மேல இருக்க கொண்டே மறந்துட்டியே.
Hey, next question. Be ready with the buzzers. Buzzer.
ஒரு தடவை செக் பண்ணலாமா?
1 second. We'll check the buzzer. ஏனா அந்த டீமுக்கு work பண்ணல.
சரி, okay.
Okay, we'll raise the hands if you know that, if at all, if you have a problem.
ரெண்டுமே பண்ணுங்க. Buzzer press பண்ணுங்க, raise hand பண்ணுங்க.
No, they are good teams. They are
It is
telling
not
us
working.
press first. Okay, so next, I'm going for the next. Keep your buzzers in hand. Identify the fetal congenital anomaly.
Team D. Team D. In the mic.
15 seconds.
Answer. 1.
Tetralogy of Fowler.
Correct. Describe the salient features
Pulmonary
of
stenosis,
tetralogy of Fowler.
right ventricular hypertrophy, overriding of aorta, and ventricular separator.
I cannot
Actually,
hear
it's
anything.
not
We
only
will not
tetralogy
score
of
you if you
Fowler,
can't
there's
hear.
something else with it, actually.
Ma'am, the characteristics of tetralogy of Fallot include a pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, and a ventricular septal defect.
Okay.
It is actually not tetralogy. Can you add one more point to this? You're nearer. Say, okay, we give it. It is
We'll give
pentology, actually.
10 plus 10.
It is pentology of Fallot, actually. But okay, we give it to them. So next.
Next.
Huh?
Next buzzer. Ma'am, சீக்கிரம் we'll go on, madam. We'll go on.
Madam, enjoy பண்ணுங்க ma'am.
அப்புறம் இறக்கி விட்டுருவாங்க. வாங்க சீக்கிரம் முடிப்போம்.
It is there, madam.
Acha. Okay. Sorry, sir.
Buzzers.
What is the anomaly seen here?
Team D.
Team 4.
Sacral agenesis.
Yes, go ahead. Next. Aneet, next question.
Okay, we'll give the mark.
Name the most probable medical disorder it is seen in.
Diabetes.
Correct.
Okay.
Slides only this.
Fine. So team D, 10 plus 10. Thank you. Do we have next? Yes.
So the
We have an
scores-
audience round, no? You can play that.
No audience round.
No audience.
Okay, anyway,
Okay.
We'll have the audience round until they calculate the score. 2 minutes.
Audience round முடிஞ்சு போச்சு.
Audience
Madam,
round
we are calculating the scores, madam.
Okay, so I'll
Okay,
move on to the next
I
question.
can announce the scores.
Yes.
At the end of the third round, Team A is 35, Team B is 40, Team C is 30, and Team D is leading with 60.
So let us see how they catch up. We move on to the round. So this is again going to be buzzer round. The team who presses the buzzer gets the answer. There's two parts. You have to answer them both. Press the buzzer and raise the hand also. If you answer partly, you give 10 marks. If you press the buzzer and if you don't answer, it is negative 5 marks. Okay, and there is no passes for this round. Is the buzzer ready? Buzzer ready?
Buzzer ready? Buzzer reset panniyachula.
Yes, buzzer is reset. Yeah, this is going to be buzzer round. Yeah. So identify the sign that is elicited.
Team 2.
Without even seeing the video, how you
Asterisk is seen in encephalopathy, hepatic encephalopathy.
What is this sign called? You have to tell the sign.
Asterisk is myoclonus.
No.
No. So we'll
Flapping
give,
tremors.
Only if you.
no, we cannot leave clues. We'll give you 10 marks for that.
Okay.
Because the one thing is, you have to wait till somebody presses to get the flapping tremor. You pressed it before that. So that is why you were not able to pick up. Okay? It was just showing the hand, and after somebody pressed, it started having the tremor. You didn't wait for that. So we'll give you 10 marks for team B.
Okay. Okay. This is flapping tremors. It is seen in hepatic encephalopathy.
No. You told it after some clues. We said you're wrong. You said something else, and then you gave us.
Is flapping tremor, no ma'am. Asterisk is flapping tremor, no.
Okay, fine. We'll give it to you. We'll give it to you 20 marks. Okay.
Sure, we'll give 20. Okay.
Okay, so moving to the next question. Get your buzzers ready. Buzzer reset. Okay, so identify the sign elicited. Which condition is it seen? Team 3. Answer.
Team C.
Answer.
Chattama, in the mic kekla.
Time is running, yeah.
Team C.
Video, after seeing the
Ajay
video, press
Robertson
the buzzer.
people.
Huh?
Ajay Robertson.
Yes,
people.
you got the
Yes.
first sign correct. Good. Which
Second
condition
half.
is it seen?
Syphilis.
Yes, you shouldn't give clues. They're hearing you, and I'm hearing what you told.
Okay. What kind of, can you explain syphilis?
Which condition is it seen? What type of syphilis?
What type of syphilis?
Yes.
Neurosyphilis.
Yes. 10 plus 10 for team C. Yes.
Okay. Okay, so it's Argyle Robertson people and neurosyphilis it is seen. So get the next question. Buzzer reset. Have your buzzers ready? Wait. Identify the sign elicited and which condition is seen.
Okay. Team B's buzzer is not working, so team B.
Team B, yeah. Tell me.
This is Homan sign to look for DVT.
Okay. We'll give you 20 marks.
So,
Okay, raise your hand,
no,
raise
but
your hand.
they raised it before you. We are sitting and seeing that only. So team B, 10 plus 10.
Woman sign and seen in DVT, yeah. Okay. So get your buzzers ready. Buzzer reset. Raise your hands also.
Not working hand only. Wait. Team B is
That's the
get it
second one
before
also.
that.
This is Cullen sign in hemorrhage.
Yes. You can give for team B 20 marks.
Team B, 10 plus 10.
Okay. Seen in Kalyan sign, we can give them 20 marks. So audience sign, we'll skip audience sign because lack of time. Okay.
Lack of time, next time.
So okay, so this is going to be identify me round. So we'll start with which team I'm supposed to start?
A, B, C, D will go with it. Or otherwise we'll start it from
We'll start from
C. We started with C. We'll start with C.
Okay, we'll start with team C. So each team gets one question. There is no buzzer. It's A, B, C, D round. Answering without clue will give you 20 marks. If you answer the first clue, you get 15 marks. If you answer the second clue, you get 10 marks. If you answer the third clue, you get 5 marks. There is no negative marks. There is no passes in this round. Okay? So team C, get ready. Team C.
Yes.
Identify this person for 20 marks.
You speak in the mic if you want the next clue.
Clue, ma'am.
Clue.
Next clue is, he is a student of Rudolf Virchow in Berlin.
Next clue.
Next clue.
What is that?
Next
Louder.
Clue. She asked for next clue.
You asked for next clue? Okay.
His research focus was metabolic diseases. Last clue is there.
Next clue.
Next clue.
Next clue. Rare malformation of tricuspid valve is named after him.
Epstein. Epstein.
Yes. 5 marks for team C.
So team C gets 5 marks. So move on to team D.
இவ்ளோ பக்கத்துல நிக்கிற எனக்கே கேட்கலனா அடுத்த தடவை மார்க் கொடுக்க மாட்டேன். இவ்ளோ பக்கத்துல நிக்கிற எனக்கு காதுல விழ மாட்டேங்குது. ஆமா. என் காதுல தான் சொல்லணும்.
Okay, so we move on to the next question for team D.
Team D.
Okay. So William Epstein. Yes. Identify this person for 20 marks.
Can you give us the first clue, ma'am?
First clue. First clue.
He was an eminent iris surgeon and founder of Dublin Journal of Medical Sciences.
அதெல்லாம் கிடையாது. ஆடியன்ஸ் ரவுண்ட் வேணான்ட்டீங்கல.
Okay, you want the next clue?
Next clue.
Next clue, ma'am.
The president of Royal College of Physicians in Ireland.
என்ன பண்ணனும் கிடையாது.
Then we have the last clue, ma'am.
Next clue.
His name is associated with hyperthyroidism.
Ma'am, Graves.
Yes.
Yes. 5 marks for team D.
5 marks for team D. Robert James Graves. Okay, so move on to the next question.
Team A, your question.
Team A, identify this person who invented this.
இது என்னன்னு கேக்கல. Who invented this? Next clue.
Next clue you want? Okay.
மைக்ல சொல்லுங்க. சீக்கிரம் டைம் ஆச்சு.
He is an Indian.
கிடையாது கிடையாது. Tell. Next clue or you want your tell the answer?
Next clue.
Next clue.
He works at Sri Chitra Tirunal Center, Trivandrum and received Padma Bhushan in 2005. I mean,
Unlucky, not your question. Any answer?
next clue.
Next clue.
He works in prosthetic valves.
Now.
No?
Okay.
Died few days back. Huh?
Yeah, few days back. No, we'll go for the patient. So no marks for team C.
Okay, the answer is MS Valliyathan is an Indian cardiac surgeon.
So it's a team A. So he's a very eminent person and he's been founder of Manipal as well. So it's a very good cardiologist and invented that. Next. Graves எல்லாம் மட்டும் என்ன நம்ம டிசீஸா? Graves Epstein's எல்லாம் என்ன நியாயம் இவரை மட்டும் கார்டியாலஜிஸ்ட்.
Okay, we'll move. This is a medical disorder round, madam. So
medical disorder.
we have to know this.
Yes.
Okay, identify this person for team B.
Team B. No, you want clue? In the
Next.
mic we can't hear.
Next clue.
Clue.
University of Texas Health Sciences Center at Houston. Next clue. Researcher and clinician in MFM, maternal fetal medicine. Last clue. Last clue. Okay. Criteria for termination of pregnancy in early onset preeclampsia.
No? No.
No?
No.
Don't know the answer? Okay. He is Baha M. Sibai. Okay.
Okay, wow, audience them.
Okay, so we had an audience round.
Audience வேணாமா?
Do you know who's this?
Audience, come on, ஒன்னு மட்டும்.
His contribution in high risk pregnancy. Eminent clinician from
Sir,
Madras.
சொல்லுங்க.
Sir, no, Chakravarti sir knows.
Sir, சொல்லுங்க.
Yes, sir.
Hey, congratulations.
Sir, lifted his hand first.
அடுத்து.
This is exemption regime is used. Okay. Padma Shri
Professor.
M.K. Krishna Menon from Madras. Okay. Okay. So we move on to the round 6.
Buzzer round.
Round 6 is a buzzer round. You should press the buzzer and raise the hands also. Okay. Buzzer. Okay. Give the exact diagnosis based on the ultrasound report.
Team A.
Achalasia cardia.
No?
Huh?
Achalasia cardia.
Achalasia cardia, no. Because
you-
the
we have a
buzzer round, there is no
remember, it's a negative
pass.
5 marks is there for buzzer round.
Yes, so -5 for team A.
It is a
No, it is no passes. Sorry,
Lambda
no
sign.
passes.
other methods to differentiate.
No
Korean
passing in
three.
this round. It's
The
a twin peak
sign,
sign, lambda sign.
Lambda sign different confirms dichorionic twinning. Okay.
Second.
But
Team
the-
B.
Ring of fire appearance in ectopic pregnancy. Ring of fire appearance in ectopic pregnancy.
Correct. You have one more add-on
Yeah,
question.
one more question. Describe the criteria for medical management.
Name?
Criteria.
criteria.
When will you give
Criteria,
medical?
just sell at least one.
One criteria at least tell.
There should be no fetal cardiac activity, beta HG less than 10,000, and patient should be stable first of all.
Okay, fine. Yeah.
Okay.
We'll give you 20 marks
We'll
for
give
that.
it to you, 20 marks for that.
Okay. Moving on to the next question. Get the buzzers and or hands ready.
Hands ready at least.
Okay. What is this disease?
Team B.
What answer?
Placenta accreta spectrum. No.
No. -5 for team B. There's no passes.
No passes. for
No
buzzer.
passes.
Okay.
So,
What is the short-term, long-term risk? It's a twin molar pregnancy. Take time to see the picture properly. It's 5% of. Okay. We move on to the next question. Get the buzzers ready. Buzz your hands ready.
Yeah.
See properly and then raise your hands. Identify the teratogen causing this effect.
team C.
Team C. Team C.
Team C.
Answer.
My God.
Warfarin and
Sorry? Warfarin? No. -5 for team C. It is phenytoin.
It's phenytoin syndrome. Fetal hydatine
So
syndrome.
-5 for team C.
Okay.
Audience கிடையாது. We are
Audience illa.
tracing.
Okay.
Scores.
At the end of round 6, Team A is 30, Team B is 115, Team C is 50, and Team D is 65. Now Team B is leading with 115.
Buzzer round was really helping them. Okay.
So now we'll go to this case scenario round. So each team gets a single question. The total marks you can get it is 30. If you answer without any choices, you get 15. I mean 30 marks complete. And once the choices are there, you get 15. You answer wrong, then before the chances are displayed, the question gets passed. Once the choices are displayed, there is no pass in this question. Okay, so we will start with team D. Am I correct? Team D has its chance. So this will be the first question. So be quieter to discuss so that the other goes on. A 25-year-old primey with a long-standing type 1 diabetes, good control with the blood sugars. Which of these complications most likely increases the risk of dying during this pregnancy? Risk of death in a lady with type 1 diabetes. Team D, your answer. You want or you want the clues? Louder.
Ma'am, clue, ma'am.
Audience, quite
Please don't answer.
You want?
They have to win a prize.
They want the clue. These are the choices. Hypoglycemia, end-stage renal disease, ketoacidosis, MI, infection.
Now it becomes easy. Think and just answer.
Team? Be louder, I can't hear you.
Ma'am, ketoacidosis, ma'am.
Sorry, wrong answer. Nobody gets a mark. The answer is hypoglycemia. No minus marks, madam. It's a primary question. So the next question to team A. A 22-year-old gravid to para 1, 35 weeks, complaining of headache, abdominal pain, nausea, vomiting, itching. She has a pedal edema, jaundice, BP of 150 or 90, blood sugar is 58, urine analysis 1 plus proteinuria, INR 2, ALT 8, AST 70, platelet 1 lakh, most likely diagnosis. You want to answer, you want the choices? Yes? You want the choices? HELP, HUS, AFLP, ICP, severe preeclampsia. Louder, we can't hear you.
AFLP.
Yes, 15 marks for team B, team A. The next question, a 35-year, for team B, 35-year-old gravida for para 1, 2 children, 37 weeks of gestation at GDM. She has last delivered 2 years back with a history of difficult forceps, in which she has a child with the Erb's palsy with residual defect. What will be the mode of delivery in this pregnancy? You want to answer? Want the choices? Team B's question. 15 for Team A. Team B, answer choices.
Choices.
Choices. Delivery of the posterior arm, Woodcock screw, elective section, cesarean with a prolonged labor, or Gaskin's maneuver.
D, cesarean if there is prolonged labor.
Sorry, they don't get any marks. It is elective section because the child has residual defect after an Erb's palsy. The next question to Team C, 39-year primary IVF conception, non-hypertensive diabetic, both are under control. Now at 30 weeks, she has a BP of 150/100 with a proteinuria of 2+. What is the most likely cause? You want to answer, you want the choices?
Early onset preeclampsia.
Sorry, she's a hypertensive. You want the choices?
Choice. Superimposed preeclampsia.
Okay, they get 15 marks. Team C. So we don't have an audience round. Sorry, we are skipping that for the lack of time. So we have a buzzer round. So if we can go, I will just finish it in few seconds. Okay. So shall we go for the rapid fire directly? Okay. Just a second. ஒரு 4 பேப்பர் வச்சு ஸ்லாட் வச்சு கொடுக்க சொன்னாங்க நாங்களே தம்பி ஒரு ஸ்லாட் 1 2 3 4 ஒரு ஸ்லாட் மட்டும் ரெடி பண்ண சொல்லல வேணாமா ஸ்லாட்
Close the slide.
சரி விடு அப்படியே போட்டுடலாமா I'm just picking up the slides. One second, I'm not, opening anything.
Meanwhile, I'll announce the marks. At the end of round 7, Team A is 45, Team B is 115, Team C is 65, and Team D is 65. 115.
Okay, so rapid fire rounds, we have 8 questions for each team. You get +5 if you answer correct, -5 for answering wrong. So if you don't want to answer, you can pass the question. Okay, we'll go in the same order of A, B, C and D. Okay, the first questions round will be, during pregnancy, cardiac output increases by what percentage?
40%.
Okay, expand the FDA. Time is. Tell me something, no? If you want to go. Okay, so next question will go. Beta blocker is particular atenolol is associated with IUGR. True, false? True. True. Okay. Pyridoxine should be supplemented in pregnancy in a woman taking anticonvulsant.
False.
False. Okay. Drug of choice for the treatment of influenza and pregnancy.
Oseltamivir.
Okay. Corticosteroid level increases in pregnancy.
Yes.
True. Okay.
True.
Time period after which the pregnancy can be safely undertaken following a renal transplant is 6 months. Tell me.
True.
True. Okay. Intrahepatic cholestasis of pregnancy occurs commonly in which trimester?
Third trimester.
Third trimester. So I will give the 20 more seconds are there. Okay. Expand FDA. The one question which you are left. No?
It is a US body. FT.
Try.
US body.
But negative will be there if you attempt.
Negative you attempt. Don't attempt.
Okay, time
Okay,
up.
fine. Pass. Fine. So I will give the answers. Kindly check the answers. 40% correct. Yes. Choice A is correct. Beta blocker true is correct. Pyridoxine supplement you said false. I hope. True you said.
False. False.
False only.
False.
False only they should.
False only you said. Okay. Correct. And oseltamivir correct. Yes. Corticosteroid increase in pregnancy. True you said correct. Time period is 6 months. You said true, which is wrong. Okay. And the third trimester is correct. So you answered 7 with 1 mistake.
So 6 correct. Okay.
6 correct. Adra
One
onnu
neg-
correct.
one negative.
5 into 5, 25. Each is 5 marks, madam. 5
Negative
plus
is?
5 negative. Okay, so out of 7, 1 is wrong. So out of 6,
25 marks.
25 marks. Okay, next questions to team B. What is the risk of superimposed PIH or preeclampsia in chronic hypertension? Okay, expand HAART. Next, appendicitis in pregnancy is associated with preterm labor. True, false?
True.
True. What is the effect of pregnancy on the natural history of renal insufficiency in the absence of any superimposed preeclampsia? Worsens, better, same, like that.
Madam, no clues.
No clue.
No, it will not improve.
Sorry?
It will not improve.
Not answering. Okay.
It will not improve.
Okay. How is any disease improved?
Negative. Give one positive answer.
Drug of choice for pustular psoriasis in pregnancy.
Steroids.
Okay. Thyroid binding globulin level decreases during pregnancy. True, false? False. Women is the greatest mortality risk of MI occurs during the late 3rd trimester.
True.
True. Which is the lab finding which confirms pancreatitis?
Lipase levels.
Serum lipase.
levels.
Okay. So we'll go to the answers.
No, time up, time up, time up.
Time up. You have spent lot of time. Okay, so the first question you didn't answer, second question you didn't answer, third question you said true, which is correct. Fourth question you said no effect, that is what I understood, so I'm giving you are correct. Fifth question steroids, I'm giving it you correct. Sixth question false is correct. Seventh question you didn't answer. Eighth question
Answered. 7th
you
answered.
answered, you said true. Is that so? Okay.
Yeah.
Eighth question lipase, I'm giving it you correct. So how many, madam?
5 correct.
5 correct, no wrongs, right?
6 correct.
Correct. 6 corrects of 30. Okay. So the next for the team C. Okay. Please answer in your mic. What is the prevalence of asymptomatic bacteriuria in pregnancy?
20%.
Okay. Expand DDAVP.
Next month.
Next to the
Okay. Most common type of AST is ostium primum defect.
True.
True. Women with an increased risk of cardiovascular complication during pregnancy with an aortic diameter of greater than 3 mm. True. The drug of choice for pneumocystic carinae pneumonia in pregnancy.
Next question.
Next. Brain is unaffected by fetal macrosomia.
True.
True. What is the loading dose of IV hydrolysine in severe preeclampsia? Passed. Most common cause of bowel obstruction in pregnancy? Pass. Okay, so expand DDAVP. No. Okay, and then drug of choice for pneumocystic carinae. No. Loading dose of hydrolysine?
4.
No. Most common cause of bowel obstruction?
10 seconds.
Okay. So we have 4 passed. I'm going to give you the answers. They have passed 4 questions. Okay. And then the first one is they said true, which is wrong. The 4th question, which they said true, which is wrong. So 2 wrongs there. 6th one, which is true, is correct. And I think first one is again wrong. So out of the 4 answered questions, 3 wrongs, 1 correct. So they get a minus of 10 marks. Minus 10 for team C. Okay, so team D, be careful, answer correctly. So, is there any questions? What is the incidence of fetal ASD or VSD if the mother has the defect?
Next question, ma'am.
Next, expand L chart, LCHAD.
We'll come back to it.
Okay, cholasma is pigmentation seen in the areola of the pregnancy.
False, ma'am.
False. Most common dermatological condition which causes pruritus in pregnancy.
And we'll come back to it, ma'am.
Okay, drug of choice for falciparum malaria in pregnancy. Most common etiology for glycosuria in pregnancy is GDM.
We'll come back now.
Okay, maximum dose of IV labetalol can be given in the severe preeclampsia.
We'll come back to it.
Okay, which type of hepatitis has worse prognosis in pregnancy?
E, ma'am.
Hepatitis E, okay. So the incidence of VSD, AST in a mother has a defect? No. Expand LCHAT? No. You're passing, okay.
marks,
Cholasma in pregnancy in the areola of
That
the
we said is false, ma'am.
false, okay. Most common dermatological condition with pruritus?
Pups, ma'am.
PUPS, okay. Drug of choice for falciparum malaria?
Artesunate, ma'am.
Okay. Most
Time
common etiology, time up. Okay, so we are not going further. So what is that is incidence of ASD you didn't answer. No. They answered, no, you didn't answer. Okay, second question you didn't answer. Third question you answered false, which is correct. Fourth question you answered PUPS, which is wrong. Okay, and fifth question you answered artesunate. Yes, that is correct. Fifth question glycosuria you didn't answer. So thankfully no negative marks. So eighth question you didn't answer. Ninth question is correct. So almost I think 3 correct, 1 wrong. So
15.
total 10 marks. 10 marks for team D.
10 marks.
Yeah. So yes, over madam. So I would
Final marks.
final marks from the scorer. So let them calculate. So I would really like to thank Cox team and Dr. Charmila madam for giving us this opportunity. Actually, most of these questions are helped and given by Dr. Ashwat Kumar sir. The only thing, there is a problem with the flight, so that is why sir could not make it up to this stage. Otherwise, like, you know, it would have been even more a pleasure to be with him. So thank you for the opportunity. Thank you, ma'am. Thank you.
Yeah, we are ready with the scores.
Yes, madam.
And we are going from the descending order. Team C with 55 marks.
Yes, thank you.
Team A with 70 marks. Team D with 75 marks. And Team B with 145 marks.
Yes.
Understand.
So congratulations, team B from Jupmer, right? Yes, so second place comes to?
First
yes,
place.
from Jupmer, first place. Second place
Team D.
is?
Team D, second place.
Second place is team D.
Team D.
Team D.
The mic, announce in mic, madam.
Announce in mic. So team D, it's from Stanley, right, doctor?
From
CMC,
Hello,
team D.
Kirtana, Jacob and Janselin. Well done, girls.
Yes. So team
Third
second
goes
prize
to Stanley, Dr. Priya S. and Dr. Padmalata.
Yes.
Yes. The leading is 145.
Yes.
Second.
And you know, like the runner-up was team from Kadalur, but we should be congratulating them. They were the toppers.
They were
in
the toppers
written
in the
test.
prelims. You did
So
very
they
well.
almost got, it's a tough question, but they answered so much. So they had really done well. So congratulations for all the winners.
All the ones. So Kadalur did well in prelims.
So thank you, thanks a lot. And totally, like, we had 82 students who participated. All of you will get a participation. Madam, a group photo alone we would like to take with our teammates, and then we will leave the stage. It's all yours.
Good afternoon. We are indeed very honored to have you all here. We move on to the oration session. Sorry for the delay. And we had 2 orations yesterday, Mr. and Mrs. Ayavu oration and South Zone Vice President oration 1 yesterday. Today we are moving to another 2 orations. First oration is by Dr. Noza Sheria sir. He was the past Secretary General of Foxy. He has come all the way to honor us, and he will be talking on contemporary instrumental delivery from obsolescence to renaissance. Now I call upon the chairpersons on dais, Dr. A.R. Chakravarti sir. He is the president of COX and organizing co-chairperson for this Southcon. Dr. Umayal Murugesan, organizing secretary, Southcon and secretary of KOGS. Dr. Jayam Kannan ma'am, mentor and ex-vice president Foxy. Dr. Leela Vyas, ex-vice president Foxy. And Dr. Chamila Ayovu, South Zone Vice President 2023. On to the dais. I request Chamila ma'am to take over the session.
Thank you, Bhuvana. Thank you so much. May I now request Dr. J.M. Kannan ma'am to accompany Dr. Noza Sheria sir to the stage and introduce the orator, please. Sir, please join us on stage.
We welcome Dr. Noza Sheria, consultant at Breach Candy Hospital and Holy Family Hospital of Mumbai. He is a fellow honoris causa RCOG, Young Gynecologist Award of Everfog, first at exam and gold medals in MD, FCPS, BGWAD, every exam. He is a member of the Technical Advisory Board, WHOC region, Chair, Medical Advisory Board, Family Planning Association of India, and he has edited 16 books and published and Amazon Best List.
It's my honor to read the citation for my teacher, Dr. Noza Sheria. It's presented at Southcon Fogsi South Zone Vice President Conference. The topic is Contemporary Instrumental Delivery from Obsolescence to Renaissance. Sir is a senior obstetrics and gynecology specialist who has been the past Secretary General and past MTP Chair of Foxy, and he's been the past President of the Mumbai Society. He practices in Mumbai and is a consultant in Breach Candy, PD Hinduja and Holy Family Hospitals. Apart from his extremely busy clinical practice, Dr. Sheria has made outstanding contributions to the academic and administrative realms of OB-GYN, not only in India but also globally. He has held important portfolios like Member Technical Advisory Group, WHO CRO Region. He's been the Chair Medical Advisory Panel of FPA India, and he's the Director Center for Catalyzing Change and Guttmacher Institute. And one of his phenomenal achievements was designing the wonderful scientific program as a chair, scientific program committee at FIGO Congress at Rio de Janeiro. His academic career has been studded with awards, notable among which are admission as a fellow, honoris causa, RCOG, and the Young Gynecologist Award at AOFOG, Dr. Hansotia Best Committee, and Dr. Datta Best Publications Award. He has been awarded Dr. Bhatia Young Scientist Award, Dr. Ganatara Community Service Award, Dr. Desai Excellence Award, Mr. and Mrs. Pandit Women's Empowerment Award, and Dr. Bhakti Think Global Act Local Awards. He has edited almost 16 books and published 40 papers and 70 chapters in various publications. He is the author of Finding Your Balance, Your 360-Degree Guide to Perimenopause and Beyond. It is now on the Amazon bestseller list. Dr. Hariharan is an example for all clinicians on how to balance clinical work with meaningful academics, and his legacy shines through his brilliant oratory skills. We, the organizing committee members of this conference, are extremely happy that he has accepted to deliver the South Zone Fogsi Vice President Oration, Contemporary Instrumental Delivery from Obsolescence to Renaissance on 21st July 2024. Signed by Dr. Jaideep Tang, President Fogsi, Dr. Madhuri Patel, Secretary General Fogsi, myself, Dr. Chakravarti, the President of Cox, and Dr. Umayal Murugesan, the Secretary of Cox. Thank you so much for accepting the invitation. Thank you, it's my honor.
Good afternoon. I'm privileged and humbled to be delivering this oration. Charmila, thank you for that very, very thoughtful citation. Jayam, chairpersons, I can see in the audience Dr. P.K. Shah, I can see Dr. Madhuri Patel. And it's amazing, it can only happen in the South that when you have a presentation at the fag end of the conference, there is still a wonderful audience to be speaking to. That's what sets you apart. So when Charmila asked me to speak on a subject, I asked her for what kind of subject that I should speak on. She said something obstetric. And I said, I'll speak on something close to my heart. And I'd first like to start by quoting Dr. Peter Chamberlain III, who said, "My father, brothers, and myself have long practiced a way to deliver patients, women, without prejudice to them or to their infants, though all others do and must endanger, if not destroy, one or both with hooks. They had a secret instrument which helped them succeed when others failed. And I believe we have an instrument which allows to do exactly the same in modern obstetrics. I talk to you today about contemporary instrumental delivery, and my subcaption from obsolescence to renaissance came almost as a tribute to the great Sir Kedarnath Das, who is our Indian historical champion. And I said, what more than honoring a quintessential British gentleman from Bengal than picking something which is quintessentially British. This is the book that he wrote. You don't have to go looking for it. You can get a PDF online. And I think everyone should download a PDF just to marvel at what this man did. Mulder had written a monogram with 43 instruments, Bush and Moser 135 instruments, Rachinsky 300 instruments, and none of these monograms were written in English. The first monogram written was by Das in 1929, when he documented and described 550 instruments. And you can imagine what a monumental task it must be. He starts off by talking about instruments which India gave to the world. We had the Garba Sanku, the Jujnu Sanku. They were being used by Sushrut, by Charaka, who described these instruments. They were basically destructive instruments. But then that was done to save the mother. But I point you to the instrument on the right-hand side, which is called the Jujnu Sanku, and I'm going to come back to that later. If you ever visit London, please walk into the RCOG. Please go and have a look at these instruments. It's almost a kind of a religious moment for any obstetrician to be standing in front of these 400-year-old original instruments of the Chamberlains. Of course, the Chamberlains were so obsessed that they kept their instruments a secret. This is the page from the monogram. These are the instruments. If I was to just say one brilliant thing that they did, they took apart the two branches. As long as you had a hinge, the instrument couldn't go above the widest diameter of the fetal head. Take off the hinge, you could put each instrument in and deliver that baby. I won't go into the history because I can do an entire oration on the history of this amazing family. You can catch it in the monogram. But this is something I want to tell you as to how obsessive they were, and in those times, how you actually kept a secret which gave you an advantage. Today we share information. Back then you hid information. This was the house of the Chamberlains in London. It's called the Woodham Mortimer Hall. And many years after the Chamberlain family had moved on, someone found these instruments under the floorboard of the attic, which are now in the RCOG. Even in their own house, they hid these instruments. I want to honor three people today when I talk about the obstetric forceps. The first is the great Sir James Young Simpson, who was a Scottish obstetrician. It said when he died, the line of people mourning went on for kilometers. We respect this man, honor this man every day with all the things that we use that are named after him. He gave us obstetric analgesia, but he gave us the modern obstetric forceps based upon the Chamberlain forceps, and we have the Simpson short and long obstetric forceps. The first transformation in the forceps came when this engineering genius, Christian Kielen from Norway, completely redesigned the instrument. He redesigned it. You suddenly had a sliding lock. You had a negated pelvic curve, because remember, they were doing major rotations. And if you had a big pelvic curve, that would really damage the pelvis. And this was the instrument that was the first big transformation. And finally, I have to honor Sir Kedarnath Das. What I've written on the right is something his son, Dr. Prabodh Das, said in his oration that he gave for his father. And I'd like to first say that this is something all of us do. Despite challenges, he personally sat for hours with laboring women, and he prioritized their well-being over rest and social engagement. I think that's something every person in this audience does. His instrument was a modification of the Simpson's forceps, but it was more delicate. And this instrument was designed by him after measuring a number of pelvis in Indian women, particularly Bengali women. It's not obsolete. I was surprised to find that you can still buy the Kedarnath forceps online. So when we talk about instrumental deliveries, why do we need them today? I sometimes feel saddened to hear that you don't need to use instruments anymore. Cesareans are far safer. And I beg to differ, because for me, one of the greatest philosophers, I just love every word this man has written. Jawaharlal Nehru said, "A policy of being too cautious is the greatest risk of all." The world has two problems. Most of the world has too many cesareans. Let's admit it. Whether it be the Americas, whether it be Europe, whether it be parts of Asia, China, but there are parts of the world with too few cesareans, particularly when you look at the Africas and maybe countries like Afghanistan. India, maybe not so badly off. We often quote a 15% figure of C-sections that WHO gave, which is not true. There is no 15% figure. It has to be an appropriate figure. And India's C-section rate of about 17.2% as a country is not too bad compared to most countries of the world. But we do have a problem, and we must be big enough to admit it. Our problem is the C-section rate between public and private sectors is just too different. It's too great. Secondly, between states, there is too much variation. You've got a state, these are all NHFS figures like Telangana with a 57% C-section rate, and then there is a Madhya Pradesh with an 8.6% C-section rate. There is a state like Kerala, which for me is almost always, if I look to ideal, I look to Kerala. 35%, but you know what amazes me? The C-section rate in the public and the private sector is almost exactly the same, which is not something any other state can say. ACOG, remember, America is the most litigious society in the world. Doctors have given up practicing obstetrics because they are afraid of litigation. Now in America, ACOG came up with a statement in 2015 and said that the use of operative vaginal delivery has decreased significantly. This decrease is partly responsible for rise in C-section rates, and these are a major concern in obstetric care. The updated ACOG bulletin came up with some very far-reaching recommendations for the world, particularly for the American gynecologist. They said that many cesareans could be avoided if operative vaginal delivery is considered an option in the delivery room. They said that operative vaginal delivery can achieve or expedite safe vaginal delivery for both maternal and fetal indications. And finally, and this is level A evidence, they said the risk of complications, which people are afraid of with forceps and vacuum, is low and they are acceptable. And that a trial of vaginal delivery is appropriate in situations for which success is likely, but the clinician must be prepared to stop if appropriate descent fails to occur. This is level 2 evidence. I can tell you today that the delivery of every patient of mine, even in the fanciest of hospital, is sometimes done in the operation theatre, keeping a backup of cesarean section on standby, and it succeeds in a majority of cases. What about this difference between forceps and delivery? I must confess that once upon a time I was identified as a forceps-wielding obstetrician. But today I must also admit that I do far more vacuums than I do forceps. Theodore Munger, Warren Buffett's very famous partner, said, "A purpose is the eternal condition of success." Let's look at the indications of the obstetric forceps. I was privileged to be working with Dr. Subhash Nargolkar. If there's a brilliant chair that the Foxy has had who inspired me, it was Dr. Subhash Nargolkar. He was the chair of our Food, Drugs and Medico-Surgical Equipments Committee. And back then in around 1988 to 1990, we did a trial of an instrument called the Hayes forceps. And I just give you the list of the cases we did at Wadia Hospital to give you an idea of the indications. Majority are for prolonged second stage and fetal distress. But you could do rotations after coming heads. We started using it at C-sections back then. This is an article from our own Indian journal. Prophylactic medical disorders, yes, prematurity. We weren't delivering too many premature babies back then. We were very cautious about it. Trial and occipito-posterior. It is believed that there are no absolute indications for instrumentation, but there are certain situations where both vacuum or forceps can be used. A delay, an exhausted mother, a dense epidural, minor rotations even today, particularly with the vacuum, and suspected fetal distress. But there are certain indications where the forceps is superior. When there is a persistent occipito-posterior. According to me, if there is one absolute indication for the forceps, it is the face to pubis delivery, which is not going to happen on its own and which is going to be extremely difficult with the vacuum. After coming head, whether it's at vaginal delivery or C-section, assisted preterm delivery, an increasingly important indication because we are delivering more and more babies today earlier because NICUs can back us up. Assistance during C-sections, I'm going to come to this as a big part of my lecture, and I have a confession to make. I now don't know whether I would be able to do a C-section if I didn't have a forceps on my table and other indications. When you compare forceps and vacuum, this is a Cochrane review. Forceps more successful. Naturally, you are holding the head, it's not going to pop off. More analgesia, more perineal and vaginal trauma. Someone just came and asked me about what I do to avoid it. Well, firstly, I do an episiotomy for instrumentation with the forceps. Otherwise, I've stopped using episiotomies as a routine completely. More third and fourth degree perineal tears with an episiotomy and a higher incidence of severe pain. C-section rates are the same. If you look at vacuum versus forceps, more cephal hematoma, so you got to be very, you can't leave a vacuum on forever. A higher incidence of retinal hemorrhage, more association with maternal worry. The first thing a mother who sees this baby with this big cone on the head, the shin on, is going to be very worried, but you have to reassure her. Higher incidence of facial palsies with the forceps, but Apgar scores, phototherapy was similar. So now, why can't we just make these instruments safe? I believe that we have lagged behind in technology with obstetrics. Everything else is technological, and we are still using the same technologies invented hundreds of years ago or decades ago. Thomas Fuller has said a danger foreseen is half avoided. Let's first now decide that the classification of forceps use has to be modified. No more old Denin's classification. ACOG says no high forceps. They do describe the mid forceps station above +2, but I think for all of us we must agree that the forceps should be applied when the station is below +2. That the forceps must be applied when it's a low forceps or an outlet forceps. And an outlet forceps all of us apply all the time, but you are permitted to do a minor rotation of even 90 or 45 degrees whenever required. Prerequisites, this audience does not need to be told that you have to be fully dilated, fully effaced, you should know the position, that it has to be vertex or a mento-anterior face. I will highlight the last one. For me, a prerequisite of the operator who's competent in the use of a forceps or vacuum, who recognizes and manages complications and who knows when to stop so as not to force the issue. I always have to keep reminding myself about the story of Mount Everest. When climbers are climbing Mount Everest, there is a time when the weather changes that if they turn back, things will be safer. But we are human beings. The summit is in sight. It's called a destructive passion. And the climber feels, I can beat the weather and I can get to the summit. Many climbers die while doing this. The obstetrician sitting there in the labor room feels the head is so close, I can do it, I can pull it out. And very often that's when we land with disasters. In fact, my associate has been empowered to whisper in my ear Mount Everest if she thinks Dr. Shariar is behaving too rash and too dangerous. You have to determine the position, posterior fontanelle, sagittal suture, fenestration, you all know that. With vacuum, the prerequisites are the same, the classification is the same. But if the vacuum pops off 3 times or more, you should be willing to abandon the procedure. We also have to be willing to wait and let nature do our task. These are 2 patients who were fully dilated for more than 2 hours, who delivered normally. They went very quickly and then they were fully dilated. You had those decelerations on the right-hand side. These are early decelerations. She's recovering well. These are not a reason or an excuse to interfere and do a C-section. And that cup of coffee there, I always believe, is my most important, valuable kind of tool, because the moment you're in the labor room and getting impatient, walk out of the labor room, go and have lots of cups of coffee and wait for nature to do its own task. Most heads will come down, most heads will rotate, and it will be easier. The French colleges recommended that routine partography is associated with a reduction in forceps because the head comes down. They said that early correction of lack of progress by oxytocin will reduce operative deliveries. Level A evidence says epidural does not increase operative vaginal deliveries, and actually delayed pushing after epidural helps you deliver patients better. Now, mid-pelvic vaginal deliveries. You have to understand that they compared dystocia and prolonged second stage, and they evaluated difficult deliveries versus C-section. Severe perinatal mortality and morbidity was there when you sequentially use two instruments, so you do not do that. Unless it's going to be easy where you rotate the head and use a forceps. If a vacuum has been difficult and failed, stop, go for a C-section. Severe maternal morbidity was not significantly different with forceps or vacuum, but sequential instruments might be more. But this is something I want to highlight. All of you know how difficult it is to do a second stage C-section and why there should be a place for instrumentation. A Canadian study looked at maternal and perinatal complications in C-sections in first stage versus C-sections in the second stage. Maternal complications, longer operative time, increased transfusion, wound infections, intraoperative complications, and maternal ICU admissions were more. Neonatal complications, low Apgar at 5 minutes, increased neonatal deaths, NICU admissions, intubation, septicemia, seizures, and fetal injuries were more. In fact, when I did a talk which I prepared for last week on postpartum endometritis, postpartum endometritis is 10-fold to 30-fold greater after a C-section than a vaginal birth. Keep that in mind. So what do you do to make the right choices? They compared all three: vacuum, forceps, C-section. C-section complications, postpartum infection, as I told you, 5-fold more. Postpartum hemorrhage, C-section marginally more. Obviously, severe lacerations were most with the forceps. Neonatal, not very different. And a cesarean section with an attempted vaginal deliveries was a little less with the forceps than with the vacuum. So can we re-engineer this instrument? And I believe we can, because David Ogilvy has said advance means progress to something better, not progress to something new. These are the instruments we all use. The Simpson's short obstetric forceps below, and the above, and the Wrigley's forceps below. I tell my students the difference is the one which is straight is S, the Simpson's, the one which has a wriggle or a curve is the Wrigley's. But the Hayes forceps that I told you about earlier, Dr. Nargolkar, is an amazing instrument inspired by the Keelan's forceps. The Hayes forceps is a straight forceps, it's a long forceps, it's got a negated pelvic curve with very delicate blades, and it has a sliding lock, but the forceps can be extended in its length. Now let me demonstrate here the application of a Hayes forceps. Firstly, this is a parallel forceps. All our other forceps are crossed forceps. In a crossed forceps, when you bring the handles together, you increase the compression on the head. In a parallel forceps, when you bring the handles together, the blades just open out. There is no compression. All of us always apply the left blade first. That's how an English lock works. But haven't you always realized the left blade is easier to insert than the right blade? So I here in the Hayes forceps always put the right blade first. It's a parallel lock, and then the left blade. I do an episiotomy when I do a forceps. The few times years ago I tried not to, I burnt my fingers and I said, that's not really something I want. And you can see here I'm extending the shanks. The forceps is made of spring steel, which is a kind of a steel which actually bends. And the power of the forceps is that you can flex the instrument and flex the head. I take you back to your exams. A flexed head gives you the smallest diameter, and the smallest diameter is the suboccipitobrachmatic. Instruments normally tend to deflex the head. And you can see here, and someone asked me, how do you avoid the episiotomy tear? Take your time. I could pull this head out in a second. Take your time. Give the perineum time to stretch, and let it stretch minute by minute, and then you get the head out. This is something I consider almost an absolute forceps indication. Okay, I might as well tell you. This is a patient where the occiput stayed posterior, refused to rotate forward. It was either trying an instrument or going for a C-section. One of my most frequent applications of the forceps today is when I have a persistent occipito-posterior position. To bring the head down to the pelvic floor, you have to flex the head initially. So first you bring it down, and once you do that and use the Pajot's maneuver, the instrument is stretched. And then you take the handles up. As you take the handles up, the head flexes. The occiput comes onto the perineum very, very low down. And once you've done that, you can deliver the baby's head by extension. And you can see here that I've extended the instrument. I'm fortunate that I've got one of these in each of the hospitals I practice in. And I've been waiting, and Dr. Nargol said, I think now some bright Indian has to go and devise a parallel forceps, even if it's not the Hayes forceps, to give us this. And you can see here you're flexing the head by taking the handles up, 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 up. You could do this with any instrument. It doesn't have to be a Hayes. It doesn't even have to be a long forceps. You could use a short forceps, preferably with a curve, and you deliver the head. This is something, again, I have come to place in every hospital. The brilliant Dr. Piley, who's someone we all love and respect greatly, who's such an innovator, came up with the Piley's forceps, where you've got two different sizes. The Piley's forceps for me is built for the small baby. Of course, Dr. Piley uses it for all babies, but here I must tell you that when I use it for my full terms, I feel it doesn't give me the kind of catch and traction I need. This is the instrument I use for the 32 to 34, 36 weeks. The smaller one I use, and yes, these days we are doing C-sections for 26 weekers, 28 weekers. The smallest I have done is a 24 and a half weeker, two of them who went home actually. Now when you're doing a C-section at that point in time, the lower segment is not formed, the head goes anywhere but the incision, and I use the tiny Piley's forceps to hold and guide the head. You can see here that this is a crossed forceps, but you're keeping the handles apart. If you squeeze the handles together, you squeeze the head. You also see here that you're moving in literally a snail's pace, because this is a cage forceps. You are caging the baby. You're protecting the baby from sudden changes in pressure within and outside the mother. And you gently ease the head out, and as you ease the head out, you gradually take out the pressure of the fetal head. The vacuum has also innovated. There are many different types of vacuum cups, but I must tell you here, I was always, this is the selection of instrument, I won't go into it, but they said that the rigid cups are better than the soft cups, but the soft cups cause less trauma. I was a big fan of the Bird's cup. If it had to be a vacuum cup, I actually looked down upon the plastic cup. But you know, in medicine, you have to keep changing your views. I don't use the Kobayashi's cup, I'm using the silicone cup now, but I started using the Mitivac. The Mitivac gave me all the advantages of the metal cup, but a good grip. But then the company took away the cup because they made it a handheld pump, not a proper pump, and now the Mitivac is only bell-shaped. So I've shifted to the Kiwi cup. I find this to be brilliant. It's so simple. You're holding it in your hand, but that tubing there has got a very strong stainless steel wire. This is just to demonstrate a Mitivac. I do not do routine episiotomies. The world does not do routine episiotomies. Cochrane tells you not to do routine episiotomies. Why then does the skilled Indian obstetrician, who's so fantastic with his surgical skills, particularly vaginal surgery, need to give episiotomies? I had an epiphany in 2016 when I had in close, one after the other, 2 injuries to the rectum. And I said, why has this happened? I remembered what Geeta Arjun had once told me many, many years ago. She said, when you go to buy fabric, you pull upon the cloth, nothing will happen. And then the salesman makes a small nick and the fabric tears. She says, every time you're giving an episiotomy, you're making a nick on the fabric. And she's so right. I have more extensions with an episiotomy than when I don't use an episiotomy. Today I deliver 85% of all my babies without an episiotomy. This last 1 week I delivered a 3.7 with a 2nd degree perineal tear and a 3.6 with a 1st degree perineal tear. And the 3.7 one I delivered was someone who was quite a celebrity, but just as I would for all my other patients, I did it for her. You can see here that Mitivac has gently brought the head down. You control the head coming out. When you open a champagne bottle, you can pop a cork or you can ease a cork. That way you ease the cork and then you take your time and gently deliver the baby. ACOG says routine episiotomy is not recommended because of poor healing with mediolateral and increased risk of anal sphincter tears. They said that OVD is contraindicated when the head is not engaged. Vacuum extraction is discouraged before 34 weeks, and the neonatal care provider should be told what you're planning. The French college says there's a place for intrapartum ultrasound. Dr. P.K. Shah is here. I think you've got to now convert all of us to the fact, put a probe on when you are in doubt and when you don't know what your findings are. It will make a world of a difference. And urgency in delivery is not the reason to choose one over the other. Insufficient data to contraindicate attempted mid-operative deliveries. So now we come to contemporary instrumental deliveries. I'm also almost out of time. Can I take a few minutes more? Thank you. George Bernard Shaw has said, take care to be born well. No sequential use. Unless turned with a vacuum on the pelvic floor forceps, justified. Otherwise, no sequential use. Immediate maternal complications, more common with the forceps. Vacuum appears to reduce episiotomies, I said that, and reduce damage to the anal sphincter. Urinary incontinence is the same. When I do a difficult instrumental deliveries, I must tell you here, I routinely leave an indwelling catheter overnight. Because these are the patients who go in, and particularly they've had an epidural. They go in for an early retention, you'll be in trouble. Leave a catheter till tomorrow morning, let the bladder be collapsed, let that initial edema go down, she'll be better. And all the other complications are the same. So where are young people today going to learn this from? Firstly, from teachers who have to inspire them, but they're also going to learn it. And Robert Frost said, the afternoon knows what the morning never suspected. Way back, we published an article in 1991 in the Asia Oceania Journal. Dr. Pandit was the editor and he encouraged us. And I can tell you that for me, if I had one conversation with nature, I would say that I'm an obstetrician, give me a handle on the baby's head so I can pull the baby out. Now, since he can't give me a handle, I said, why don't I create a handle? We are using fan and steel incisions. Our patients are more and more obese. Elective sections you do very often have a floating head and the head will go everywhere except come to the incision and the anesthetist is literally sitting on the patient. You have a patient where there is an anterior placenta which doesn't allow the head to come down. This is simple and straightforward. This is any simple instrument. Though I would prefer a straight, short obstetric forceps. You put in the posterior blade first, then you put in the anterior blade. I use the C till the very end and at the last moment take it out. And you will see here, and I'm not saying that we have to be vain, but I believe our patients want small, beautiful fan and steel scars. Please, just because it's in a place where people can't see it does not mean we have the right to give her an ugly scar. And you can see here we've not even wasted a millimeter, because if I was to put my hand in, my incision would have to be that much bigger. I waste not a millimeter. Now, there are certain other things I'm demonstrating here. For me, forceps is routine. And I tell my patient about this beforehand so that she doesn't feel, doctor, what's this mark on the baby's head? But sometimes you have a deeply engaged head. You put one hand down and you actually, it hurts you, but you feel that negative pressure suddenly going. Now you want to leverage this head out. To leverage this head out, you can use a single branch of the forceps. The Vectis came from one of the chamberlains going and actually cheating the Dutch college by selling them a single blade. And the single blade is your Vectis and you can leverage it out. You can also use a vacuum. I don't, but there are people I know who do and I'm fine with it. You can use a vacuum to deliver the head at C-section. My problem with the vacuum is twofold. Number one, it never gives me the control I want. I'm depending upon the machine or something else to control. And number two, I don't get a great position near the occiput. So it'll go wherever you reach. In a vaginal birth, you can slip the vacuum, and you can see here, it's there, but that vacuum cup is not really the occiput. It's on one side, but the principle is the same. I believe that today for any preterm baby at C-section, even if you're not routinely doing it, please use an obstetric forceps. Please have control. In fact, this is the baby. You should not be pushing extremely hard, fundal pressure, all kinds of stuff happening. You want to bring this baby out very, very gently. And this is the piles. And again, I can just show you. I will increase this incision by a few millimeters on either side as per requirement. Tailor your incision to the head. Don't waste even a millimeter of space. And take your time getting the baby's head out. I believe the next generation will learn breech delivery at C-section. They won't have an assisted breech, they will learn breech extractions because you are holding the baby by the pelvis. Your Pinard's maneuver to get the knees out. There, by flexing it. Sweeping the hands down, releasing the cord. Bringing the baby to a mento-posterior position. And personally, even in the days that we did vaginal breech deliveries, I believe that the best way of delivering the head was a forceps. Because that way what happens, you control flexion. And doing a forceps for and after coming head is the simplest thing in the world. You have to start doing this in the easy cases so you can effortlessly do it in the more difficult cases. So someone just wraps up the baby, holds it up. Normally we have this green cloth and we are holding up the baby by a stalk. And you can see the head coming out there by flexion. You can sometimes have challenging situations. This was a baby who was face. And there was the face in the incision and I'm trying to get it out and I just couldn't get that head to flex. I said, now what do you do? Well, you use your imagination. And what I did was, I'm waiting to get it out and that face just won't come out. So I applied a forceps. Within a second, you flex the face and out walks the baby. Okay? So that's how you could have probably done it for the face. And yeah, and you'll see here in a second, the face is out by just flexing the head. So now I'd like to end by saying that Ralph Waldo Emerson said, nothing great was ever achieved without enthusiasm. Our great teacher, Dr. V.N. Purandare, once said casually in a lecture that students are not here to worship knowledge, they are there to question it. To the young people in the audience, I tell you, start questioning what we've been taught for some time now. Start doing your own. Today you've got YouTube videos. There's so many things you can teach yourself. In fact, a study in the UK showed that when there was formal education and teaching of the forceps, there was a decrease in cervical, labial, high vaginal tears, less NICU admission, less scalp injury, less facial injuries. So we have to teach our next generation something that's so amazing. Herodotus said, force has no place where there is a need of skill. He could be talking about all obstetrics. He could be talking about all medicine per se. It's never about force, it's about skill. I went to the London Science Museum many, many years ago, 30 years ago, and I took a picture of that instrument on the left. Many years later, I saw this picture in the monogram written by Sir Kedarnath Das. He said it was a destructive instrument, but when I compared it to my Hayes forceps, I said, that is a parallel forceps. So thousands of years ago, there was an Indian instrument which looked like the Hayes forceps. Hippocrates said, primum non nocere, first do no harm. Whatever we do, whatever we practice, first has to be about safety. It's not about us, it's about her. It's about her being safe and her being in the center of the equation. That's why we exist. Thank you.
Thank you so much, sir. I request you to accept a small plaque on behalf of Kanjivaram OG Society.
I request Umayal ma'am to present the plaque.
Anybody from the organizing team, please come on to the stage.
So it's a honor from our society to hand over this wonderful thing, sir. Southcon Fogsi VP South Zone International Conference on 18th to 21st of July at Hotel Carlton Samudra, hosted by Kanchipuram OG Society, is honored to present this plaque to Dr. Noza Sherier. Sir, we thank you and we are very honored by your esteemed presence to deliver the South Zone Foxy Vice President's oration on contemporary instrumental delivery from obsolescence to renaissance on July 21st, 2024. Signed by Dr. Jaideep Tank, President Foxy, Dr. Madhuri Patil, Secretary General Foxy, Dr. Charmila Iyavu, Vice President Foxy and Organizing Chairperson, Professor A.R. Chakravarti sir, our Organizing Co-Chairperson and our Society's President, myself, the Organizing Secretary, and Dr. Vijayalakshmi Sabha, the Organizing Treasurer. Honor, sir. The speech was wonderful.
I request Madam Dr.
Take the eyes off
Madam
your
Sherier
videos.
to come on stage, please. Please. It's a small gift from our side.
From Kanchipuram Society, Kanchipuram, sorry.
Now we move on to the next oration. The last session for the conference it is going to be Dr. A.R. Chakravarti oration. The oration actually it is a regular annual oration on behalf of the Cox Society. We do it every year in our conferences. This year we are proud that it has been incorporated in South Zone Vice President Conference by Dr. Charmila Iyavu ma'am, and the orator is also ma'am, Dr. Charmila Iyavu. We are happy to have you here ma'am. The oration, Dr. A.R. Chakravarti oration, it's all about the pre-eclampsia, the escalating inferno. I request Dr. Charmila ma'am to come over the dais to present the oration. I ask Dr. Umayal ma'am, Secretary Cox to take over the session. I request Dr. Vijayalakshmi ma'am, Organizing Treasurer of Southcon, to take position as a chairperson. Thank you ma'am. Over to you Umayal ma'am.
Happy afternoon. Very happy to hand over the mic to Dr. Jaya madam to say a few words about our dear President sir, on whose name this oration has been installed. Thank you.
Good afternoon to all of you. Last year also, I had the proud privilege of introducing your own great person of Kanjivaram Society, the area of Chengalpattu. I think many of us are Tamilian. Am I right? Anyhow, I'll speak. See, when I have the name Chakravarti, we all think that somebody from Calcutta has come in. Correct? Chakravarti or Chakravarti, whatever you say, that name comes from Calcutta. Anna, Namma Chakravarti, Katbadi la porandar. Born in Katbadi to an Iyer family. And he has been named as Chakravarti by the traditional South Indian Brahmin family. Usually Chakravarti means it's a Vishnu name. So by name he is an Iyengar, but by birth he is an Iyer. And Katbadi, Chengalpattu, Chennai. Only this area, right from birth to this age of 70 plus, he is within the 50, 60 or rather 100 kilometer circle. But many of us are not that way. We are born somewhere, we work somewhere. So this is a big credit for Dr. Chakravarti, and he is known to everybody here with all his education, but more than that is his willingness to teach everybody. Even at dead of night, doctors call him, ask him for opinion, and he gives directions how to deliver. And he sees that that doctor delivers the baby and tells him back that everything is all right. Which senior is now willing to do it? Am I right? This is the great achievement, and this is the great pride of this Kanjivaram society to keep him as his president. Long live Dr. Chakravarti, and over to Charmila for his oration, who will be introduced by the next person.
One nimsham, madam. Now, Dr. Leela Vyas, madam, will be introducing the speaker, our dear Vice President 2024.
From South Zone. It's my great privilege to introduce Charmila, and she is Vice President Foxy 2024, South Zone. But I would like to say that I know her from the 18 when we all were together. She was working as a chairperson clinical research committee, and I remember she got the best committee award. And not only that, the Charmila got this, there is a real sense she is a research person. Any of the webinar for the last this COVID time, we are attending that Charmila is there, we always get relaxed that Charmila is going to tell each and everything about the subject. So you always justified your position as a research, clinical research chairperson, and this is one of the big achievement for all of us, that this person, and she is going to deliver that oration on the name of the sir, who was a dedicated person for the society, for all of us, all Foxians, all, I would like to say not only for the Kanchipuram, it is for all of us. And Charmila is ICOG Governing Council member. Yes, the research person should go into the ICOG. National Coordinator for the UNICEF Foxy PCA program. And we all associated with so many programs always through the webinars. And we have seen her knowledge spreading nature. She always spreads the nature knowledge among all our juniors. She is a series convener for the ICOG Journal Club, WHO South Asia Regional MDSR Indian member, President Menstrual Hygiene Management Consortium in 18 to 20, Secretary Gestosis, and she is managing committee member of the PCO Society, which is again one of the problem in our country. So we all expect that you will grow faster and more on heights. And
thank you so much.
She is also the MD of Aditi Hospital from Trichy. She has not mentioned that. She's got a great practice at Trichy, and she is also an infertility specialist. Now next to the formalities, the shawl will be adorned by Dr. Chakravarti sir. The medal by Jaya madam.
May I request her teacher, Foxy Secretary General, to come and bless her student.
Medal. Very emotional moment. Congratulations, madam.
I'm so lucky that on day of Guru Purnima, I'm honoring my student, and you all gave me the opportunity to say it. So really, I must say she's the most dedicated, most sincere when she was working in my unit. And I'm happy that she has climbed the ladder, and I want more feathers in her cap. So Sharmila, all the best, and my blessings are always with you.
The citation I will be presenting. So I'm just going to read the citation. Southcon Fogsi South Zone Vice President's Conference, Dr. A.R. Chakravarti oration on the topic of pre-eclampsia, the escalating inferno. The citation is given to Dr. Charmila Ayavu, MD DGO, DFP, FIC, OG and PGDCR. Dr. Charmila Ayavu is an outstanding OB-GYN practitioner with a strong base of clinical experience, in addition to fantastic achievements in academics and research. She hails from Trichy in Tamil Nadu, and with her hard work and dedication has taken her city into the global map of excellence in OB-GYN. She is the director of Aditi Hospital and Parvati Ayavu Fertility Center, Trichy, and a visiting consultant to Southern Railway Hospitals, Golden Rock, Trichy. Despite her busy clinical practice, she has contributed immensely to community service and has held several important administrative posts in the OB-GYN societies in the regional and the national level. She is presently the Vice President of Foxy 2024, ICOG Governing Council member, and also the VP of the Trichy OB-GYN Society. She has held several prestigious administrative positions in the past, including the chair of the Clinical Research Committee, Foxy, National Convener of UNICEF Foxy PCA 2020 to 2022, and a Foxy representative to the National Inspection and Monitoring Committee, convened under the PCPNDT Act, among many other responsibilities. She is the recipient of many prestigious awards and honor, and notable among which are the Helping Mothers Survive Champion Prize of Foxy in the year 2013 for conducting programs to reduce the maternal mortality, Mr. and Mrs. Pandit Award for the year 2015 for the work on women empowerment by the Foxy, and Dr. Mehru Hamsonia Prize for the Best Committee by Foxy in 2018. She received the MS Signature Award 2022 for the extraordinary contribution in the field of medicine by creating awareness of menstrual hygiene in the adolescent girls, and also empowered them in social and health issue by conducting innumerable camps in rural areas. She is the winner of the highest number of prizes as Secretary of the Trichy OB-GYN Society. They are the President's Rotating Trophy for the year 2013, Dr. Durusha Youth Trophy Awards for the year 2012 and 2013 twice, and Dr. Sadhana Desai Population Stabilization Prize for the year 2012. Dr. Chitradhara and Gangadharan Prevention and Research in Oncology Award for the year 2013. Dr. Chamila hails from a traditional family with strong cultural roots and an extraordinary modern approach that empowers her to take on the challenge of society flawlessly, emerging as an achiever in her own right. Apart from this stellar career in practice and advocacy, she is an excellent academician known for her very fulfilling lectures and brilliant publications in journals, books, and reviews. She works with a passion that is infectious to the team around her and has excelled as a leader in Foxy, inspiring the younger generation to take on greater responsibilities. The best is yet to come for this young achiever, and the organizing team wishes her all the very best for the path ahead. We, the organizing committee members of this conference, are happy that she has accepted to deliver the day to the Dr. A.R. Chakravarti oration, Pre-Eclampsia, the Escalating Inferno, on 21st July 2024. Signed by Dr. Jaideep Tank, President Foxy, Dr. Madhuri Patil, Secretary General Foxy, Dr. Chakravarti A.R., President Fox and co-chairperson of Southcon 24, and myself, Dr. Omiyal Murugesan, Secretary, Organizing Secretary of this conference. So it's a big honor for us.
I'm extremely thankful to Kanjivaram Society for giving me this opportunity. Special thanks to Dr. Chakravarti sir who's given this opportunity to me. When we go on to this topic of preeclampsia, the escalating inferno, in the United States, the rate of preeclampsia increased by almost 25% between 87 to 2004. And that is almost like a lady who's delivering in 1980 compared to a lady who's delivering in 2003. She would have had a 6.7-fold increased risk of severe preeclampsia. It's climbed up so much. Risk factors, as we know, nullipara, primary paternity, advanced maternal age, previous preeclampsia, high body mass index, diabetes, multiple gestations, assisted reproduction, pre-existing medical conditions are all risk factors for developing preeclampsia. And this is the gestosis risk score, which will tell you like the high risk of her developing preeclampsia. Score 3 is when she has got a metabolic disease already, like a pre-gestational diabetes, a chronic hypertension, mental disorders, inherited or acquired thrombophilia, maternal chronic kidney disease, APLA, autoimmune disease like SLE, and when she's delivered, when she's become pregnant with assisted reproductive technology of ovum donation or surrogacy. The most common risk factors if you take for developing preeclampsia is, first is multifetal gestation, and the moderate risk factor is a low socioeconomic status. And how much has these risk factors increased over the years from 2010 to 2021? Chronic hypertension has seen a 125% increase. Pre-gestational diabetes has increased by almost 57%. Obesity is increased in women by almost 35%. And advanced maternal age for delivery has increased by almost 36%. IVF pregnancies, almost 200% increase is there. And interpregnancy intervals has increased by almost 12.5%. So these are all the risk factors which is contributing to a increasing preeclampsia rate. And the difference because of economy will be, there is a decrease in incidence in high income countries, and that's because they've got quality prenatal care and adequate management of cases of preeclampsia and eclampsia. But the low income countries have got an increase in incidence, that's because reduced access to quality care and the poor management of cases is a reason. The risk profile has changed also. In developed countries, it's more of incidence in low risk nulliparous women, and it's more common in multiparous women when they got a high risk condition. And also there's a difference in risk factors between the early onset and late onset preeclampsia. Early onset preeclampsia is more common in multigravidas, especially when they've got chronic hypertension and there's a past history of preeclampsia. Late onset is more common in women who are preemies and over the age of 35 with a BMI more than 35. And there's also a rural-urban difference. That is, earlier it was more common in rural areas compared to urban areas, but now there's an increasing rates in urban areas, and that's not because of, the gap is not reduced because of a change in the management. It's basically because the urban areas are showing a much greater increase compared to rural areas. So the gap is becomes smaller. And the most common reason for this gap becoming smaller is the increasing prevalence of chronic hypertension across all age groups of women, and the unfavorable patterns and maternal risk factors in both rural and urban areas seems to be obesity, decreased physical activity, and the diet changes which has happened, and these have contributed to an accelerating rates of hypertensive disorders of pregnancy in recent years. The urban risk factors which have contributed to a higher risk of preeclampsia is the pollution which we see, the air pollution, the environmental noise, crowding, urban planning, and unavailability of green spaces have all contributed to a higher rate of preeclampsia. And I'm seeing the environmental committee person is going for election is also stand. Please remember that we have to reduce all that. And pre-existing diseases, the increased occurrence of preeclampsia becomes more because the stress of pregnancy may expose a subclinical vascular disease. Earlier we were thinking that preeclampsia de novo happens, but remember, suppose she's already got a predilection for a cardiovascular disease, when she becomes pregnant, she will show preeclampsia, and that means this patient is always prone for cardiovascular disease. So the hypothesis has changed now. It is not that the placenta should be concerned as a villain, it's actually the victim. Because we thought it was a primary placental disorder, but still we have not shown any evidence for that. And now there's emerging evidence that preeclampsia is due to a secondary placental dysfunction, and that's because there's a suboptimal maternal cardiovascular performance which goes on to cause the uteroplacental malperfusion or hyperperfusion. It's not vice versa. And there are now abundant studies that state that cardiovascular dysfunction precedes development of preeclampsia by several weeks or months. So the mother is already prone for preeclampsia, and when she becomes pregnant, she shows the disease. And obesity has increased so much, and the high prevalence has showed a substantial implication in pregnancy, because obesity is shown to be associated with an increase in hypertensive complications. And what about body mass index? Suppose the mother is pregnant, but is obese even before she's pregnant. That is, the pre-pregnancy maternal corpulence is associated with metabolic factors, other than diabetes, because along with diabetes, you'll have other metabolic parameters which are deranged, and that is associated with late onset preeclampsia. And that's why the discrepancy we are seeing, because high income countries have more of obese women, and they've got a higher incidence of late onset preeclampsia, whereas the low income countries show more of early onset preeclampsia because they've got risk factors like they are more thin and they've got a lower socioeconomic status. And with every increase in BMI, that is, it almost like doubles the number of preeclampsia cases, and the mechanisms have only been partially explored. They've said it may be an increased cytokine-mediated inflammation and oxidative stress, maybe an increased shear stress in the vessels, can be dyslipidemia, and maybe an increased sympathetic activity, and these can all have been proposed as possible pathways for the development of preeclampsia in obese women. And the next factor which is causing an increase is the assisted reproductive technology, which is being used without discrimination everywhere. It has caused almost a 1.7-fold increase in the development of preeclampsia. And how does it happen? Abnormal placentation per se can influence preeclampsia. And in some assisted reproductive procedures, the blood flow is compromised to the endometrium and is actually diminished, which is then followed by obstetric complications. And placental insufficiency per se can happen because of the altered hormonal environment in the endometrium. And it has also been argued that the technique itself will have some epigenetic effects on the embryo and the placenta. What about donor gametes? Pregnancies conceived through donor oocytes have shown an increased risk of preeclampsia in the mother. And here, that's why it's now considered that the placenta may not be the villain. And there's a role of maternal immune reactivity against foreign fetal antigens. So it's got two fetal antigens to fight against, both the ovum as well as the sperm, because primary paternity we know has caused a higher risk of preeclampsia, but the other way, when you use a donor oocyte, that is also a foreign antigen for her, and that's why she shows a higher incidence of preeclampsia when there's a donor gamete pregnancy, and that's almost like a 25% increase in the incidence. And what about frozen cycles? When you have an artificially induced endometrium, there will not be the corpus luteum. When the corpus luteum is not there, you will not have the hormone relaxin. And when relaxin is not there, it is going to compromise the maternal cardiovascular adaptations in pregnancy. And that is why in an artificial cycle, when you're using frozen embryos and you're going to artificially stimulate with both estrogen and progesterone, instead of going for a natural cycle transfer, it's going to increase the chances of preeclampsia. And recurrent miscarriages are also associated with a higher chance of preeclampsia. And because per se the pregnancies from ART are associated with oxidative stress, and in addition they also have some form of reproductive dysfunction which has got the same strength as miscarriages. And that's why when the patient has got recurrent spontaneous miscarriage and you also put her on infertility treatment, that is going to increase the risk of preeclampsia in compared to women who do not undergo those forms of treatment. And what about recurrent preeclampsia? Remember that recurrent preeclampsia, we are unable to reduce the incidence over the last 2 decades, and that is because there's a higher incidence of diabetes, obesity, and chronic hypertension in our mothers, and that's why we are unable to reduce these metabolic factors, and that's contributing to recurrent development of preeclampsia in each pregnancy. And it is much more increased when the recurrent preeclampsia happens when there's been a baby which is delivered either preterm or the mother has had a cesarean delivery. That means she was induced much earlier, and that will be the risk factor again for the next pregnancy. And the rising maternal age is the next risk factor for the development of both early and late onset preeclampsia. And there's also a higher incidence of severe forms in these older mothers. It can be HELLP syndrome, acute kidney injury, and also new onset postpartum hypertension. She'll be totally normotensive throughout her pregnancy, and post-delivery, you will not even notice, but a hypertension will develop, and that can cause severe complications because you left her unnoticed. And older mothers, when they've got smoking habits and they've undergone assisted reproductive technology, it's going to much more increase the chance of preeclampsia. So how are you going to de-escalate the inferno which is happening? You have to at least reduce the modifiable risk factors of preeclampsia, such as chronic hypertension, pre-gestational diabetes, and obesity before she conceives. And for that, we need public health efforts, cannot be done in a single day. And how will you manage chronic hypertension? Remember to treat her with adequate, appropriate antihypertensives. And I know Dr. Jayam Kannan is a proponent of that. You can give the maximum dose of antihypertensive drugs to keep her under control when she's a chronic hypertensive. And remember to monitor the mother and the baby. Surveillance protocol should be on point for a mother who is already a chronic hypertensive and she's entered into pregnancy. And what about hyperglycemia in pregnancy? Remember that type 1 diabetes will increase the risk of hypertensive disorders when almost by 9 to 66%. But don't forget type 2 diabetes also, which is also increasing in our mothers, and that increases the risk by almost 5.2 to 8.2% of hypertensive disorders. There's been a paradigm shift towards the importance of type 2 diabetes in pregnancy, which was not there 2 decades earlier. And the prevalence of type 1 diabetes almost remained the same. It's just increased by 0.24 to 0.3%, but type 2 diabetes has increased by almost 33% in our mothers. And the prevalence of type 2 diabetes has also increased the chance of hypertensive disorders. And that's why you have to remember to monitor these type 2 diabetic mothers also, keep them under control before they become pregnant, because they also have the same complications as a type 1 diabetes when they become pregnant. What about HTP development with with hyperglycemia? The most important factor which will cause the mother to become hypertensive will be the poor control of her diabetic status. And that is because we insufficiently treat her before she becomes pregnant. We just assume that nothing will happen. But remember, mothers of infants with FGR and diabetes will have a lighter placenta compared to the macrosomic babies which can happen in GDM. And this lighter placenta, and they will also have a considerably higher need for insulin dosage at delivery. That means they are very, very severely diabetic, and these mothers will have a FGR baby, and that's going to cause more problems. And the placental dysfunction which happens because of this change will also contribute to her to develop hypertensive disorders. And BMI is a very, very important part of the mother developing preeclampsia, and that's increased tremendously over the decades. If you see the older textbooks like Kosmak in 1931, Diekman in 1952, Davis in 52, and Leon Chesley in 78 and 99, none of them cited overweight and obesity mothers as a problem for a development of preeclampsia. But now you will see that all the textbooks quote obesity as a major risk factor for the mother developing preeclampsia, and that's because it's become like a tsunami now. Obese mothers are becoming increasingly seen in the population nowadays. And being overweight or obese is the most important risk factor for both preeclampsia and severe preeclampsia, with an attributable risk factor of almost like 64%, 64.9% in both the groups. So having an overweight or obese mother entering into pregnancy is like inviting trouble of hypertensive disorders. So you need to reduce the complications, and for that you need to promptly identify the disease when she's pregnant, prevent the progression to a severe maternal complication, and you have to give timely treatment for that. And identification monitoring, for that you need to have prediction of the risk factors and preventive strategies implementation in your center. And you need to measure her blood pressure throughout pregnancy, which should also include self-monitoring, because it's worthwhile buying a blood pressure machine and giving her and asking her to monitor herself at home. And how do you screen for high-risk women to prevent this disease? FIGO says all pregnant women, it needs to be a universal screening of every lady who walks into your antenatal OP to be screened for preterm preeclampsia during early pregnancy by the first trimester combined test as a one-step procedure, because like DIPSY, you need to call her at least only once, and you have to screen her for that. And it has to be both maternal risk factors and biomarkers according to FIGO. And when you want to prevent preeclampsia, the drugs which have been advised are very few, but they should be given. And the first is aspirin, given at a dose of 75 to 150 milligram per day. And she should start preferably before 16 weeks of pregnancy, should be taken at night and continued until she delivers. And when you cannot assess the intake of calcium in her or predict it, it is reasonable to give calcium to all our mothers. And please remember to ask her to exercise at least 3 days per week for an average of 50 minutes using a combination of aerobic exercise, strength and flexibility training. Because we are seeing our mothers, the moment she becomes pregnant, she just sits in a corner, thinks everything will happen by itself, and they think that taking rest will actually prevent diseases, but it's vice versa. So the timely treatment which needs to be given to any mother who's been diagnosed with hypertension is antihypertensives, give anticonvulsants when there's an indication, and for that magnesium sulfate is the only drug of choice, and appropriately time her delivery. And the newer preventive strategies which have been tried nowadays is they are changing from 75 milligram to 150 milligram of aspirin, and they are now taking up metformin as a target of studies for preventing hypertension. And Pravastin has also been tried now, and they say it's a good option to prevent preeclampsia. Proton pump inhibitors are being studied for prevention of this disease. And the ASPIR trial is a trial which compared a dosage of 150 milligram of aspirin versus a placebo, and they said it reduced the incidence of preterm preeclampsia. But they didn't talk anything about late-term preeclampsia, and they did not talk about a comparison between 75 and 150 milligram of aspirin. They just compared 150 milligram to placebo. And the next drug which has come into the picture is metformin, and they say it reduces the secretion of anti-angiogenic factors from the placenta in a dose-dependent manner, and they say it will mitigate the endothelial dysfunction and can promote vasodilation in whole maternal omental blood vessels in studies done. And it may also have some angiogenic properties which can promote vessel outgrowths from aortic rings obtained from mice studies. And the next drug which has been tried is pravastatin, and they said it has got a beneficial action on both placental and the maternal vascular diseases, and they said it promotes a favorable angiogenic profile by decreasing the secretion of SFLT1 and SFLT endoglin. And there are a large number of trials underway, but they will get over only in 2031, so you have to wait for those results. The next drug is proton pump inhibitors like lansoprazole, rabiprazole, and esomeprazole. They say it decreases the placental release of SFLT1 and endoglin in vitro at much lower concentrations on pravastatin, and they say it reduces the placental and vascular pro-inflammatory cytokine production, and it will mitigate the endothelial dysfunction. This may also facilitate a favorable vascular dynamics as it upregulates the phosphorylated nitric oxide synthase in endothelial cells. So to reduce the complications, please give equitable strategies to identify and monitor this disease. Quality improvement initiatives for prompt treatment are needed, and you need to increase the awareness of danger signs. These three things are needed to reduce the complications of this dreaded problem. To summarize my talk, the inferno of preeclampsia is blazing. Please reduce the modifiable risk factors like chronic hypertension, type 1 and type 2 diabetes, and obesity. Avoid late motherhood as much as possible. Assisted reproductive technologies for conceiving should be used with caution. Predict and use preventable strategies to reduce the disease burden. Identify, promptly prevent progression to severe forms of the disease, and provide timely treatment. Educate regarding warning signs, otherwise it will engulf the future also, because new onset hypertensive disorders of pregnancy are associated with almost doubling of the risk of coronary heart disease, heart failure, stroke, and cardiovascular related mortality, and it accounts for almost 44% of deaths within the first 6 days postpartum. Additionally, the Cardiovascular Association of Hypertensive Disorders of Pregnancy will extend to the offspring also, who will have an increased risk of hypertension, obesity, and lifetime cardiovascular disease into young adulthood. Remember, you need to prevent both for the mother as well as her offspring. Thank you so much for this opportunity, Dr. Chakravarti, Dr. Umayal, and Kanjivaram Oji Society. Thank you so much. 20 minutes to
Thank you, ma'am. One important announcement. There are 3 workshops scheduled for today, one in Hall B, Hall C, and Hall D. Post-conference workshop. Hall B, you have endoscopy, and Hall C and D, you have cosmetology and infertility workshop. It has already started. Whoever has registered, please go to the schedule room. Now for the memento presentation, valedictory session will happen here, Hall A.
So quiz prize winners. Plaque will be given by Dr. Chakravarti sir.
On the day of Guru Purnima, for a guru to bless her daughter, her student in person, adoring her with medal, is something which Guru will remember ever in life. The student also will remember ever in life.
Southcon Fogsi Hariharan South Zone International Conference, 18-21 July 24 at Hotel Kaldan Samudram. Hosted by Kanjivaram Opsi Society, Dr. Charmila Ayav. We thank you and are honored by your esteemed presence to deliver A.R. Chakravarti oration on preeclampsia, the escalating infirmo on July 21st, 24. Signed by Dr. Jaideep Tang, President, Madhuri Pari Madam, Secretary General, Charmila Madam, myself, Umayal and Vijay. Thank you, Madam.
And we like to offer all token of a gift also to Madam from our Cox Society. A small gift from the Cox Society to Madam who had been helping us for this society. And it was a great opportunity which we didn't miss out from Madam, and really thank you for that. We really appreciate you and we are grateful to you.
Thank you, ma'am. Thank you so much, ma'am. This conference was supposed to be done a year back. It was lost to us, but we have done it and we have showed the world that we can do it well. Thank you, Kanjivaram Society and all the members. You worked so hard for this conference and it showed in the way where everybody gave their feedback. I'm extremely honored to conduct the conference with Kanjivaram Society. Thank you so much. Thank you. Thank you, sir. Thank you, madam.
It was so smooth. The responsibility of நம்பி இந்த வேலையை கொடுத்துட்டு ரொம்ப கேள்வியே கேட்கல. அதான் best part. So
the responsibility was given, handed over to Mayal and Kanjivaram Society, and Charmila has not asked them anything. Sometimes I used to ask Charmila, what is this? Madam, it is 3 days since I have talked to Umayal. See, just 10 days before the conference, the organizers, the chairperson and the secretary have never talked. That means each person believes the next person so much. The confidence level is so high that they didn't even have a need to talk to each. That is what she meant.
When we got the opportunity from Madam to conduct this program, really it was happy, but same time that fear started inside. We were really thinking we'll be able to do it. And then as Sir and Umayal Madam all, okay, we'll try, and said, okay, we all started. Past 4 months, we have not slept. And last 3 days, we have not closed our eyes. And we are just waiting. And you're happy that all our individually, every committee member and Cox members, as Madam said, we didn't interfere in any of their programs. They did by themselves and then helped out. Thank you.
Yeah, 2 more things. Can I request our senior most member, P.K. Shah? You know, P.K. Shah has been a president in Foxy about a decade ago. Am I right? Yes. And myself and Charmila had the, P.K. Shah, please come to the dais, had the privilege of doing 2 CMEs by 2 different sponsors on one day. Morning one on infertility, evening one CME on endoscopy, 2 different sponsors. He gave permission because he knows that we will utilize the fund properly. And please bless your student on the Guru Purnima day. Yeah. One more thing, is now that Madhuri Patel Madam has been here for all the 3 days, and we all know very well that she is going to occupy the supreme post of Foxy President in the year to come. We request her to think of giving a major national conference to this Kanjivaram Society. On behalf of the society, I request you, Madam, to think that the minute you become the Supremo, Kanjivaram Society is the first #1 for conference in the South.
Madam Jayam, I have already decided before you say. They will get a big conference, definitely. And I must appreciate Dr. Jayam, Dr. Vijaya Lakshmi, Sharmila, Chakrabarti sir, Umyan, and I don't remember your name. Bhuvneshwari. They've really done excellent job. Conference to arrange is not a simple thing. As she said, she has not slept for 4 months, but I'm sure Sharmila and Jay must not have slept for 6 months, 1 year. I mean, Umiyan. All three of them not slept for 1 year. So, to have such a successful, a grand success, without, your hard work, it never comes. And PK Shah sir knows it, how much hard work we have to do. I remember when we are doing the conferences, we are really doing hard work, and everywhere, every place, you have to shout at somebody if the work is not getting done, or you have to be very, very polite. But work has to be done. So I'm really congratulating all of you for this excellent conference, and I have never seen such a people, delegate coming in such a high numbers and making this as a grand success. This is because of your academics and love to all of us, and I'm really happy for the same. So once again, congratulations.
Our academic in charge.
Scientific really, the scientific academics are excellent, and I'm really happy. 4 days conferences. 4 days. Yeah, that is, you have made a benchmark of the conferences of the Foxy. So what else I can say? This is really wonderful, wonderful time I had. Thank you so much. Thank you so much.
Before sir says, I would say that our major guru is Dr. J.M. Kannan. She's been the backbone of all of us, and as madam said, half the time when she calls up, I won't pick up the phone because I know madam is going to shout at me.
நான் எங்களுக்குலாம் மேடம்னா பயம் ஏன்னா வந்து அவங்க மெசேஜ் போட்டாலே when she puts a message she will never put a message, she'll be just observing, but when something goes tweaks little bit lateral, immediately a message will come, then only we know she's seeing the messages. Till then we won't even know, then we will all scramble, oh what's happened like that. But that was very now we realize the small things actually makes this get even better and better.
And she's a guru of all gurus.
First of all, let me congratulate the whole team of this conference, VP Conference South Zone, and especially the team from Kanjivaram. We have fallen in love with southern part of our country. When we came to Tiruchirappalli, right? I think I visited both the places, Jayam's and her houses, and even Deepa's, I think, Deepa Mukundan's place also. And I always believe that representation of South in Foxy was not very good. So we wanted South to represent continuously in Foxy without fighting. Because we don't want to lose a single person from South. And that is why whosoever is contesting from South, see that there is no contest amongst people from southern part of our country. Select one person, everybody should support that person, and that person should come to Foxy. Whether it is chairperson's post, vice president's post, president's post. Okay? So that is one thing which I feel I should have told you. And I'm really thoroughly pleased when Charmila told me that you don't come on 18th. I was displeased because I had almost booked my ticket, Mahabalipuram, because this is some new place which I have visited in my life. Normally we go to same place again and again. But I'm thoroughly impressed with this place and the whole team, the way you people have worked, very good food, very good hotel, yeah. And I can't believe that such a thing can happen. So congratulations from the bottom of my heart, and I wish you all similar thing in future also, and I'll be here every time you have any academic activity. Thank you very much.
We can break for lunch. Those who have had lunch, please attend the workshops. They are all different combinations, and all eminent speakers all over the country has come all the way to the workshops. Please, and we will meet again at around 4 o'clock for valedictory. 4 o'clock.